Everyone a bit more time to get on. Hi, Chantal. Thanks for joining and for recording us. Much appreciated. Thanks, Louise, for giving her a heads up.
No worries.
Oops. How are you? Are you enjoying some time off, I hope?
Yeah. I'm not working
Ish.
all day, every day. Is that sort of like time off?
That's an improvement.
Yeah. I really resent that the government always decides that it has to do things in the summer. Never, like, really.
Yeah.
Yeah. Really nice to have a summer off.
Yeah, agreed. Okay, so let me check in again. Are Barry or Cheryl Ann on yet? Oh, there's Cheryl Ann. Hi, Cheryl Ann. I see you. But
I am here.
Great. Hi. And Barry, have you joined us yet? Not yet? Okay. I trust she'll be on soon. So just checking in. I know we have Stephanie on the line, Mark, Cheryl Ann, Alan, Louise, John, Rose. This is Leah speaking. Is there anyone else on the line that I haven't named yet? Okay, well, we have 2 chunky chapters today, so I think we should get started so that we hopefully have time to get through both of them and not have to cut ourselves short in discussion. So Chantal, please feel free to hit record anytime. And thank you again for helping us with the recording of this. A few people did send in their regrets, and I know that they're really appreciating having the audio recordings to go back and check what they missed out on. So I will bring up some slides for Chapter 3, kindly prepared by Mark, who will be facilitating our discussion today. So just give me 1 second here, Mark.
Sure.
And I'll get these up. So for those of you who are on the phone, they were also sent by email. So feel free to, they were sent this morning, so feel free to open them up on your own computers if you want to. They're very brief. So if you don't have them, don't stress too much. I know Mark will take us through. So over to you, Mark. Chapter 3, How Reform Went Wrong.
Okay. I just wanted to start and check to see if anybody had any introductory comments about their thoughts on the chapter before I dive into it.
Oh, all right. Well, let me think about that for a minute. Let me see if I wrote any big holy smokes things in it.
I think for myself, my personal overview was that it was really effective at driving home what values-based healthcare is. However, for the purpose of this discussion, it wasn't overly effective because it was so US specific that so much of it didn't apply to what we would be doing in Canada. But it did give a good view of, by highlighting what the initiative was and then why it didn't work towards the outcome, it did help solidify the purposes of value-based healthcare.
One thing, Mark, that I found very interesting was the managed care section starting on page 76. And I even though you're quite right, a lot of sort of the actual problems are not so specific to Canada. The issue of under-treatment and over-treatment actually I found quite resonated a lot for me. At least in its own like doctor-patient experience. For example, my GP will not renew prescriptions without you going into his office. And I understand that for some things, but there are some things that I've been taking for like 10 years And unless my medical condition changes, I'm going to be taking them as long as they keep working for me. So forcing me to go in every year to, to renew a prescription that we all know I'm just going to keep taking until we decide I'm not, is just money in his pocket, money and time wasted out of mine. And I don't think there's any productivity there. So to me, I don't know if that's really over treatment exactly, but it's certainly over healthcare. It's more healthcare than I need. And I think that happens quite a bit. And I mean, another thing that I hear from patients is about their primary care physicians or GPs, whatever you want to call them, thinking that they can deal with medical issues that probably are way above their pay grade. Particularly, I know one that thinks he can manage everybody's mental health issues. And we know of cases where what he has done for long periods of time has actually been counterproductive. And when the person finally, and made the person feel like, don't go anywhere else because that'll upset me. And then when the person finally did get to a proper mental health facility that understood these things, it turned out that, what had been prescribed over and over for this person was profoundly wrong. So I think that, the outputs-based payment system is creating over-treatment in some places and under-treatment in the right places to some extent.
Yeah, I completely agree. And I should have started by saying that while it was very US specific, what I tried to do was go through and pull out items from each of the pieces that did apply to us. And I was hoping that that would open up some discussions like the one you've been starting with there.
Yeah. Because I do think that some of the problems that he raises are, like that one, certainly are just as Canadian as they are American.
Yeah, I have a few thoughts to share too, but Mark, I'll wait till you kind of take us through the first, take us through an overview and then jump in. I do think that the chart on page 72, sort of where it brings it up to a higher level, figure 3.1, the evolution of reform models, sort of past, present, and future, is a little bit more helpful because it rolls things up to less specificity of the US experience and sort of talks more at a broader level, the types of reforms that have been applied. And I would say that many that are listed in the past are still active currently, certainly in Canada. And then I would add a few others that are still active in Canada, but I'm going to hold my thoughts on that until later in our conversation.
Okay.
This is, sorry.
I
think I want to add a little bit to what I just mentioned, and then that figure 3.1 as well. Mentioned that in the past, U.S. was trying to reduce costs, and they're trying to enable more choices now. And I think in Canada, we're moving backwards, where we're trying to reduce costs right now, and we're reducing a lot of choices. And we're definitely moving not in the direction of the value healthcare system, but actually the other way around, going backwards.
Yeah, that's an interesting observation.
Okay, I think, does anyone want to do an overview of each of them, or should we go to the discussion points?
The different US initiatives?
Yeah.
I don't think so. Has everyone read the chapter? So, you got a sense of the different, you got a sense of what each of these different initiatives look like. Does anyone want to do a quick overview of each?
I think you'll see if you move to slide 3 that I pulled out the most relevant that would apply to us, I think, please jump in if anybody got some other ones out of it that I didn't.
Yeah. Great. Do you want? It's not. Some people are on the phone and may not have the slides in front of them. Mark, it's unfortunate we're on hold. We can hear that, but anyhow. Do you want to just do a quick overview of some of the discussion points you highlighted here?
Sure.
Thanks.
Okay, so the first one I think is the most relevant, and we did start the discussion with, this is the fixed fee service that incentivizes to treat rather than to minimize the fee for treatment, prevent disease, or improve healthcare value. And I think that's the big one for us, and that we probably all have good examples of.
Yeah.
Pardon?
Yeah, so the fee.
Sorry, I just want to let you know it's Louise, and I saw that Barry was calling me, so I went on hold, and she's having trouble getting in, but I've given her some more numbers, and hopefully she'll be in soon.
Okay, great. Thank you.
All right.
So yeah, so we were just touching on some. I don't know when you went on hold, Louise, but sort of Alan. We were just looking briefly at that figure 3.1, which is on page 72 of the book, which does a good job of sort of rolling up the different reform models to a more general level, not so U.S. specific. And I made the comment that I thought a lot of the sort of reduce cost and avoid cost type of reforms that are identified as the past are very active currently in Canada. And Alan went one step further and said, actually, it seems like, you know, we're moving backwards, and so reducing choice and going, you know, to increased cost shifting and that sort of thing. And then we're going to go into more of that as we get through our discussion. And Mark is nobody wanted to do sort of dive into the details of the different U.S. initiatives because we've all read the chapter. And Mark is kindly taking us through a few discussion points that he pulled out. To get us going. And the first one is what you were describing earlier, Louise, sort of fixed fee for service type of payments, which incentivize overtreatment in many cases and doesn't incentivize necessarily disease prevention and certainly doesn't lend itself towards improved healthcare value. So just to summarize, and back over to you, Mark.
Sure. I think the big piece with that, and it goes with what Louise was saying as well, is that I don't think anybody disputes care providers wanting to get proper funding for their time. It's just, it doesn't always seem to be the most streamlined process with the patient in mind.
Right, and the payment mechanisms are basically incentivizing the wrong thing. So for example, when there's changes made to any of the schedules of payments for physicians that are being paid fee for service, it can actually sometimes lead to changes in treatment practice, to this whole thing of under and over, you know, treatment. So urine tests are reduced, you know, in how much they're paid for each urine test. All of a sudden, a lot of different methadone doctors close their practice because they decide they're not going to make enough money anymore. So because they need those urine samples, and they're probably overusing the urine samples anyhow in the first place. But so then all of a sudden they're just not delivering those services anymore, and they're moving to other practice areas. Yeah, there you go. Fixed fees by diagnosis.
Yeah, I think I pulled this one out mainly because it's a big thought I've had in the back of my mind all the time that, you know, I understand in the values-based model how you're getting there, but it comes up to as well to collecting the data and having all of the outcomes data based on how you're going to fund for that. So the severity issue has crossed my mind a lot because, you know, treating for say when someone comes in with a sign of a heart attack, and what it ultimately the outcome is it really is going to impact the cost and how you're funded on it.
Mm-hmm. Right.
So in the example in the book, it was causing hospitals to discharge early because they were getting a fixed fee anyways. And so it wasn't necessarily taking the patient's best interest or treatment plan into play.
Yeah, and I'm not as familiar with the reforms that have been happening in hospital payments, but I believe there's been this move from global budgets sort of to quality-based procedures, is my understanding. Oop, there's some feedback going on somewhere. There we go, it's gone now.
Okay.
So my understanding there, and please correct me folks if I'm wrong, but again, it's focusing more on sort of process standardization, and it's still, I believe, sort of incentivizing volume. So it's sort of how many quality-based procedures, but don't quote me on that. But certainly at a larger systems level in Ontario, there's this growing focus on quality improvement, quality-based procedures, and quality generally, and but often with a more, and they address this and talk about this in the book as well, but more of a focus on process and not results, right? So so again, focusing on the wrong, on too much on the means, not enough on the ends. And sometimes leading to too much standardization and focus on standardization, so that you don't get necessarily, you don't see the innovation that's happening and then scale those across the systems.
Yeah, even my experience working at a CHC, leading the quality improvement plan for Health Quality Ontario, it was very process specific. It was about doing more with less, rather than really looking at the patient focus of how do we make their experience better. Of course, that was part of it, but it was very process focused.
Yeah, and one part of quality improvement can be so it has the patient's experience improved, but yes, we're not getting our eye on the end goal of, are they getting better given the conditions that they're dealing with? Yeah. Or are we preventing and keeping them in good health, so to speak, or preventing further decline if they are dealing with a chronic condition, for example?
This is Alan. So yes, I think that this discussion definitely. So in one of the chapters, I think it starts on page 84. It talks about incentive for compliance, incentive for actual health outcomes, and I think a lot of the hospitals or a lot of the healthcare services right now are leaning towards the compliance, especially at least in many parts of Canada. Yeah. And I think it's also because last time we were talking about the CIHI hospital data, and this is, I haven't looked into this yet, and I don't know if that data is being used to look into whether or not is it compliance, or can it be used to study actual health outcomes rather than just compliance.
Yeah, it's hard to tell when they keep most of it internal when they are reporting back to the providers. Mm-hmm. It's because people are still afraid to share. So that's the other big. If you ever did start getting to those outcomes measures, the ability to convince all the different providers for that data to be publicly available, so that themselves they can learn from each other, but also the public and other providers, et cetera, can also make more informed choices. That would be a big step, because even where there is some work already happening with limited data, et cetera, such by groups such as CIHI, for example, the data is kept internal to the provider organizations that are providing that data. So it's hard to tell, and we can't really answer those questions well because of that, because it's not transparent. Mm-hmm. But yeah, to your earlier, I would agree that what's described in sort of past reform models is definitely very much actively in play. As this came up in our last conversation in Canada, which system characterized by cost shifting among patients, providers, physicians, payers, employers, and government. Limiting access to services, bargaining down prices. Prices being disconnected from the actual economics of care delivery, and then what they're mentioning as sort of present trends focusing on provider and hospital practices, these are also active. You know, Six Sigma, sort of volume thresholds, mandatory guidelines, standardization, compliance, as people mentioned, quality improvement or quality process focus. It's still focusing on sort of bargaining with physicians, specifically on payment practices that are focused still on fee-for-service or capitation, and which tend to create the wrong incentives for value-based healthcare. The other big one that I think is quite common coming out of public systems in Canada and in other countries that isn't named here, probably because it hasn't played out necessarily in the US in this way, but is regionalization. So I see it as maybe a form of sort of managed care, but this is the creation of regional health authorities. And so basically government becoming the actual provider of care. I went back to, in Ontario in Canada is sort of the outlier in that we've gone only partially towards regionalization with the establishment of the local health integration networks, but haven't gone the full 9 yards like other provinces and territories, because the individual providers on the ground, whether they're hospitals or primary care teams or mental health providers, et cetera, they haven't, other than the CCACs, the rest of the providers haven't actually been consolidated under the regional health authorities. In most of the rest of Canada, the regional health authorities have taken over the individual providers' agencies and are delivering the care. So they're not just planning it, but they're actually governing care delivery as well. So that's another trend, and I'd be happy to share a paper that is about this topic specifically, and it's a bit of an overview of sort of how effective has it been, and what it, you know, there's a few things that it says in there. Number one, there's no real, there isn't an actual, there's not a lot of good data, and there's no sort of research framework that has been set up around this, but certainly in most jurisdictions there has been a lot of tinkering with regionalization. Every few years the number of regions changes, or they collapse it back to one region, like in Alberta. So now there's just one regional health authority covering the entire province. So there's a lot of sort of tinkering with the approach, and not a lot of data that says whether or not it's working or not. And certainly in this paper, they specifically say that there is not a focus on results. There isn't the data infrastructure that's been put in place to measure them, and that sort of thing. So regionalization is definitely a form of reform that has played out in Canada, and certainly in the UK and Australia and other single, payer or public payer, government payer systems that I thought should be mentioned too.
I'd be interested in seeing that paper.
Yeah, it's Barry. I wanted to ask a question. I don't know if there's a way to raise your hand on this, but when you say regionalization, you're saying that as opposed to what?
As opposed to what existed before is you had a sort of central ministry, because in Canada, it's the provinces that deliver healthcare. So there would be a central ministry that basically was the set the policy frameworks, the regulatory frameworks, legislative frameworks, funding flows, planning, all of that sort of lived within a central ministry of health. And then all the different providers would be, funded through the Ministry of Health to deliver care. So what shifted over time is that basically those individual, often the community boards of those different provider agencies in different provinces, they were collapsed. Basically, those provider agencies became an arm. The government created regional health authorities, so sort of arms of themselves that are in the regions, and then they brought the different provider boards underneath those regional health authorities, so that those regional health authorities, i.e. government, became the providers. So the same, you still have a social worker on the ground, but the people, so they, but the actual sort of governance and oversight of that care delivery moved to the government regional health authorities and away from individual agencies delivering care.
Okay.
So
yeah,
this is the whole issue of how we, like, I don't know that, personally, I don't think we should get too granular about all this stuff, because in terms of the way we're presently constructed. First of all, every province is constructed differently. And second of all, if we move to a value-based healthcare system, one would hope that we then construct, I mean, that's the tail wagging the dog. Once
exactly.
we have a value-based healthcare system, and then obviously we'll need to reconstruct, deconstruct and reconstruct the existing systems to match what we've decided we're actually doing. So, I mean, I think that generally the conclusion I would draw about all of that is that it's obvious that the governments haven't figured out a really good system for of monitoring and, and implementing our healthcare structure the way it is. And that, obviously on the table will have to be a complete new restructuring based on what we decide we're going to do. And hopefully we can have a better idea than they've had so far.
Agree. Generally speaking, sort of these, and part of what different groups seem to be saying when it comes to value-based healthcare is let it come from the bottom up. Oftentimes when it's sort of this whole system that's consolidate under the, what they were doing with CCACs, et cetera, it creates a lot of chaos in the system and sort of takes people further away from working towards common ends, such as, okay, let's redefine value. How are we going to get towards those results, outcomes? How are we going to work across the whole sort of cycle of care so that we're making sure we're having the best outcomes for the most in the most cost-effective fashion. So usually when there's a big, okay, system-wide tinker, mandatory, thou shalt all do this, it takes everybody into a state of panic and chaos and advocacy that is counterproductive. Yeah.
And every time they change it, it takes years and years to get that right, and then they change it again. So
exactly.
Whatever we do, let's try to do something that's either easily changeable, let's not try boiling oceans and stuff, and then we find we boiled the wrong ocean, and then we try again.
Yeah.
It's Cheryl Ann here. I just wanted to say that what I found was missing in the areas of, how did it go wrong, what went wrong, what's not working, is I don't think they focused too much attention on the pressures of the pharmaceutical industry and the medical device industry. Because that pressure is that they are all trying to divvy up a market, and own diseases and medical conditions. And then when you do that, of course, they don't want to share any information because it's, to them, proprietary information because they innovated something. So this also creates a pressure that if you don't break out of that cycle and kind of look at what is best for Canada, let's say, and say, hey, we have huge gaps in whatever our top illnesses are where we haven't been innovative enough, and coming to them and saying, we need you to innovate this. This is what we really need. Which is not happening now. It's more or less driven by what the innovations come from pharmaceutical and medical device companies, right? So they kind of missed that point, that's another outside pressure point that is ultimately going to make it very difficult to implement a value-based healthcare.
Yeah.
I don't know if anybody else felt that way. I mean, that was just a big thing that I kind of saw reading that chapter.
Yeah, I mean, and add to that that they're not dealing with their contributions at the level of the full cycle of care for the disease. They're only sort of looking at the stuff they're producing and how they can maximize their profits versus how it applies to the patient for the full cycle of care.
Yeah.
Right, and one point I'd like to make about that is that we've all been seeing about like CAR T, for example. And so if you just focus on what the pharmaceutical company can do with CAR T, that's one thing. But what doesn't take into consideration is all the money the hospital systems have to spend themselves on managing patients who are on CAR T, and the full spectrum of care that those patients are going to get. So let's say, you know, right now we heard the market price is $450,000 for one, you know, go at CAR T for ALL, I understand. But what it doesn't, you know, that's $450,000 is what the patient needs to pay, but it doesn't look at the 2 weeks of almost ICU care that the patient is going to require, at least minimum. And it doesn't look at what is going to be the aftercare for maybe a year or 2 or 3, even down the road afterwards, for all the other special things that that patient's going to need for patient support.
So if I write about value-based healthcare and how it would work, given your example, if the analysis was that the thing for this person is CAR T therapy, all of the costs, as I understand it, since everybody would be working like in a team rather than in these silos, all of that would be factored in to the cost for that patient. And we wouldn't run into exactly what you're talking about, which is because of all the siloing.
Correct. And this is where I'm saying it gets difficult because the pharmaceutical company providing that specialty will want to keep a lot of that very proprietary.
Maybe, but they're just not going to be, I mean, they're not going to be able to keep the cost what's going to be involved proprietary if they're going to want to get it funded.
Agreed.
Yes, this whole nature of sharing information, it will be challenging, and this certainly came out in the book as well. In these chapters, I'm trying to remember if it was chapter 3 or chapter 4, but even just at the provider level, how slow it is and how much resistance there is to sharing data, right? So in this case, it's costing data or whatever the case may be, but there's a lot of fear, and we currently have a system that keeps, where data very much by and large is kept internal, where it exists, for a variety of different motivations, and certainly sort of the proprietary profit motive is one on the pharma and medical devices side. Yeah, but I mean, that's exactly the goal. I think it sounds like from the experiences that they're describing in the book, and from what we know about human nature combined with sort of the power of these different groups, this will definitely not be a quick shift. So how does one incentivize that shift? How do you get the consensus of people? Who could be early adopters, for example, who might be willing to start taking on these types of practices and opening up data and sharing. So,
it's all the part of like what Louise was saying. You really have to completely deconstruct what you have today in order to reconstruct, and who gets to carry that ball, who it's not just as easy as getting you know, making your physicians compete more because of the value they can offer the patient. There's a lot of pieces.
Yeah.
I mean, the way I see this happening is that it's going to have to be mandated through government or law or something, because I feel like, you know, one of the reasons there is this resistance to focusing on outcomes or sharing data that will establish what the outcomes are is it forces people to be accountable, and people don't want to be accountable if they can get away with not being accountable.
Got
it. And so I think they're going to pretty much have to be forced into it with a government that is focused on the best outcomes for the patients, which certainly isn't true with some governments. So yeah, I mean, I feel like it's going to have to be sort of mandated to a large extent.
Oh, I think it's going to have to totally be mandated. I agree with you completely. Unless the government changes, certainly for Canada, its reimbursement process and structure and all of it. I mean, it is going to be a complete change in the focus of how healthcare is done. For instance, right now in Ontario, our new wonderful new government has set up this guy for $350,000 a year who's going to solve the problem of what has been defined as hallway medicine. So I want to make a guess. I don't mind if I'm wrong about this, but I'm afraid I might not be. That what he's going to come up with is open more wards, give more money to hospitals, build more hospitals. And the fact of the matter is that, if it under a value-based healthcare system, what should happen is, it shouldn't, that's the tail. Again, it's the tail wagging the dog. The real question should be, why are these people ending up in emergency rooms and in hospitals? And the fact of the matter is, most of us know that many people shouldn't even be there. They should either be at home through home care, they should be in a rehabilitation facility, they should be in a palliative care facility, they should be in a retirement home. And I will bet you that in the usual way we do things, instead of actually looking at the real problem and therefore and of course, adding on to that all the issues of social determinants of health and housing and all these things, I bet you that what's going to come out of this is just the same old knee-jerk stuff, like, oh my goodness, just give the hospitals more money. So all you're doing is incenting the power base we already have, when it's the power base we already have that's actually the problem. That's my feeling about it all. We just never really want to get down to what the problem is.
And my early worry as it relates to value-based healthcare and how it might be implemented in Canada specifically is that the sector, certainly, it seems to be most on top of this conversation, and part of the early piloting that's happening in this area is the hospital sector exclusively. Those are the only providers currently, part of some pilots that are being rolled out on this, et cetera, and looked at being spread, et cetera. So are we, and we'll get into it, I think, when we talk about the principles of value-based competition too. I think that I agreed with so much of what's in here, but I also found that the perspectives for some of the principles and for some of the examples and stuff, and for some of the thinking that's been happening here, the most mature thinking on it seems to be coming from specialists' point of view and hospitals' point of view, which is good and it's important, and I can understand why that's the case. But in the early part of the book, they talked about value being delivered for specific medical conditions and or patient segments across the whole cycle of care. But as we got deeper into the principles, it just became about the medical conditions. And so, which which is absolutely, and they bring in prevention there too. So I get it. I get how that's all trying to be wrapped around. But when you think about it from the part of the system that is looking at family medicine, that's looking at primary health care, that's looking at, how, there's community health centers, for example, Mark, where it's not just primary care, but you are trying to also connect with different aspects of trying to address people's determinants of health, so that you're able to support patient segments that are often more marginalized in society and face greater barriers. And so you're trying to enable the access, but also and then enable prevention, health promotion, and where and then where there are already conditions going on, make sure that they're having the most coordinated care possible when they're entering into specialty care, other arms of the system, hospitals, etc. How are you making sure that there is that coordination across everybody, so that you're providing the best care across the entire cycle? So anyhow, this often happens with reform, right? And so is that there's a lot of really good ideas, but then usually the same power bases, which often is hospital led and physician led, and often sort of specialist physician led, tend to dominate the agenda and kind of take the reform in a particular direction that maybe ends up just creating more status quo. So part of the thinking as this is all unfolding and as we move towards a summit, et cetera, is from the patient perspective. How do we make sure that we're working with key players and et cetera, to really make sure that the patient perspective is really embedded in this, and it's not just specific to certain provider types, et cetera, that we're keeping to the core of what seems so promising in this approach of outcomes of importance to patients, for the best possible cost over the entire spectrum of care.
But I think the thing that we keep bumping up against, and I think it's an important question for us to answer, not on this call, but before the end of all of our review of this book. I mean, let's face the, sad facts of life. We're the least powerful almost.
Yes.
I mean, in these big monolithic systems, in terms of money, I'm just looking at, money is power. So getting people to, it's fine to say, well, we're going to convince them of the importance of patient engagement. Well, we haven't done it yet. So, what's going to be different this time? And I think we really need to think about that. And I think that my instinct is that rather than trying to convince them anything about patient engagement, for the benefit of the patient, even though that's what we want, I think we have to play in their sandbox, which is, why is this a better thing for them? And by them, I would say saving money for the governments, because that seems to be their big deal. And, how do we, and finding some players like retirement homes and palliative care facilities and others that will actually do better under this system. And maybe we just have to get working with all of those groups and accept that we're going to have to make a circle around those existing power players who are not going to want to do it, and just hope we can find enough of the other power players that we can kind of wrestle them to the ground. But honestly, I think us thinking that the way to go at this is to convince people that they should do it because it'll get better patient outcomes is a waste of time.
Yeah.
I don't think anybody cares about that except us.
Yeah. True.
And a few doctors from time to time.
Just acknowledging time to, did we want to wrap up chapter 3 and move to chapter 4? Thank you so much, Mark, for bringing up these great discussion points and getting us stimulated in this conversation.
Okay.
Was there anything else anyone wanted to raise as it relates to Chapter 3 and how reform went wrong? Okay, so Chapter 4, Principles of Value-Based Competition. We have both Barry and Cheryl Ann who are helping us with this very meaty and central chapter. And so just wondering, I don't know if there's some different slides you guys want me to bring up. I'm happy to do that.
So Leah,
yeah.
it's Cheryl Ann. I just only a few minutes ago sent out what I did to the entire group in a PDF format.
Okay, great. Let me get that.
So,
yeah,
oh, sorry, Barry, what were you going to say?
I sent some slides too, but the only one that needs to be shown is the one that lists the 8 different principles.
Agreed. But I want to talk a little bit about what I sent, because only because I did it so different from you, Barry, so it's actually complementing very well what we're doing together. I felt because this was such a big chapter, and it was really going to set us up for understanding how do you do value-based healthcare, that I actually went very methodically through the whole chapter and picked out some big highlights of text that they said, the points that they were making. So mine's really, you've got most of my slides there. I'll have the rest of them this afternoon. But I think it's kind of good because some of these statements you could probably, we could probably talk to, but as you can see, it's very, I did pick out, like Barry did too, I listed the 8 principles. But so, just so you can see the difference between what Barry did and what I did.
Okay, I don't think I have, but
I think the one thing I'd say overall, and I don't know if you'd agree with me or not, Barry, but I don't know if it's just me, folks, so, if you disagree, that's fine. I just find there was a lot of redundancy. It seemed to me that they're saying it, and then they're saying it 5 different ways, the same thing on certain things. So I found that a little frustrating, and that's why I kind of highlighted a few, like some of the text that I found was not so redundant. But that's just me.
Yeah, I found the same, Carolyn. Yeah, it's Rose. Yeah, I found exactly the same. I think Mark did too.
I was like, God, this is crazy. You're just saying the same thing over and over again, but saying it in a different way. So, go ahead.
I wondered if that was I wondered if that was intentional.
That's what I was thinking.
Yeah, that it's so obvious that that's what's going on that I was wondering if somebody told them people need to hear things X number of times before that sinks in, or people need to hear things X number of different ways before the light bulb goes on. I don't know. I thought it had to be they couldn't possibly have not recognized that in the editing process.
And the other thing I wanted to say is, I don't know also if it's me, but it just seems to resonate so strongly with me that it's not complicated to understand that this is obviously what we always have been needing to do. It's just so obvious after you've looked at these 8 principles that how could we even have thought that we should do it any other way?
Yeah, true.
Because it does it is, and this is the thing that I find kind of funny. Everybody, for the past 10 years, all we've been hearing about is patient centricity. And let's be clear, we all believe we have not been patient centric at all. We're always on the outside, screaming to get in, and they're mocking us by using patient centricity right to our face, and then totally not listening to what we need. Whereas when you look at a value-based competition, if you look at these 8 principles that Leah's put up, you can clearly see you can't even start anything until you look at what is the needs of the patient. So, which is something we're really not doing, right? Or we say we're doing, but then we don't listen. So,
Right.
so with that, I mean, you can see these 8 principles, and Barry, do you want to talk to some of them, or?
Well, I was just going to say, I mean, you all were talking about the redundancy. I think there's really only one principle, and these are sort of the underpinnings of those principles. And the principle is that competition needs to be based on the outcomes versus the process, or versus, making sure everybody gets their piece of the pie. I mean, that's the zero sum versus the way this would work holistically. So I see it as one principle. And this is kind of what goes into it, which is, I think, also making it redundant. But I was hoping we could have kind of a discussion amongst everybody as to what they, and I feel like some of these on their face are a little bit counterintuitive, but if you understand it better, or if you've read it or can think of examples, they make sense. That we could just talk about each one, maybe talk about what the challenges are, give some examples, and think also outside of the box. I mean, principles can be applied to other systems, and sometimes it helps me to think of examples that aren't even in the healthcare system, to sort of illustrate how this principle would actually work. And the book here is, it kind of went, this is where the book goes from what the problem has been to what the solution is. And I think going forward, it then breaks it out by what each, cog and the system's wheel will need to do in order to implement these principles. So yeah, I was just hoping to maybe, see if other people had any questions about any of these. And I've got prodding questions if people don't.
Barry, I think it's interesting, your comment about, are these really all principles? And I agree with you entirely. It's kind of a mixture of the way, when I put together kind of sort of strategic planning and work planning sessions, as much as I hate doing them, whenever we do, we sort of start with a vision of the world as we'd like to see it, and then the values that we hold, inviolate in getting to that. And then we come down to sort of vision, values, objectives, and then how you're going to achieve it. So I agree with you. I think our real vision of the world would be a place where everybody is as healthy as they can be, based on the value that they place on certain outcomes. And that's really like the world that we'd like to live in. And then we have certain values, which I don't see most of these as sort of the kind of values, like values. I think of values as things like, it shouldn't matter where you live or what money you have, you should get the best outcome. And, those kinds of things as kind of values. And then most of these end up being things you're actually going to do to get there. There's steps in the process. Like one step is creating competition, creating a way to measure competition, and making sure that competition is measured over the full cycle of care. And most of these sort of, another is value. So we're going to measure provider experience and learning. All of these are quite granular, actually, rather than being high level principles, I think.
I tend to agree with what you're saying, Louise. I mean, I can't help it, and everybody probably gets tired of me saying this, but when I'm looking through reading this, I look and I measure it up to my medical condition. And
that's all you can do. I mean, that's our frame of reference, right?
Right, right. So for me, that's helped because, but it also puts a lot of questions out there. I'm just very fortunate for my medical condition that we got a drug that really hit the mark. It was just serendipitous. Nobody was expecting that, but here it did. Now, because of that, it forced, you know, all the countries in the world who wanted to bring this innovative medicine to their country, it forced them all to set up and study independently, and mostly it was driven by the European system to just how do you do this? How do you implement this very innovative but highly costly drug into this, you know, disease state, and what do you hope to get out of it? And so, interestingly enough, that has forced them because to come together collectively as a specialty. And again, it was something driven by the European specialists, which now spilt over to the rest of the world. And they now actually have every year a specific meeting on this disease state where they challenge each other how to actually further improve. And at all steps in what they're doing when they set up these like global guidelines, and many governments and countries in the world have accepted them because they work, and it does present real value. Interestingly enough, they came up with the idea, you know what, you don't probably have to take this drug for the rest of your life. Maybe we can get more people to stop taking the drug if we, you know, really look at the whole care cycle of the patient. So they actually can't, I see it happening in my disease group right before my very eyes in real time, that they've had to do this all with, interestingly enough, pushing back the pharmaceutical industry that was putting on the brakes every step of the way. They really didn't want to have these discussions and fund clinical trials that would actually allow patients to get off the drugs completely and be monitored with other, you know, innovations that are not theirs, like more diagnostic stuff. So it's been interesting to see them have to walk this very delicate political, diplomatic line with them. And I can see it then. I have hope that it will spill out into other disease groups, but it wasn't something that anybody set out and planned to do. It was all very serendipitous. So it just naturally evolved into a value-based competition within my disease state, because the market itself became very appealing to a couple of other pharmaceutical companies along the way. So I can see it working.
But isn't all this again like further proof that our system is wrongly constructed? Because
yeah, totally.
Yeah, because if we were constructed on a value-based basis, then doctors really do feel, I think, in general, and I underline this in general, that, you know, when you go in to see them, you expect to walk out with a prescription. Like, I think they feel that, and they don't have a lot of time to see you. So that's an easy way of getting rid of you within the 7 minutes or whatever that they're paid to see you, at least in Ontario. And, you know, so I think that, you know, as long as there's no, I don't want to say there's no point in hoping that your experience will spill out. Of course, you can hope, but I think the chances of that happening the way the system is right now, the chances are not that good, right? So it really, again, is another example of why we're all upside down in terms of the way we should be paying for things, and I guess rewarding and recognizing and frankly punishing. You know, that's what people respond to. And so far, we're just rewarding the doctor for getting you in and out in 7 minutes and giving you something that makes you think you're happy when you leave the room. And that's about it. It's terrible to say. That's about it.
But Louise, it's Rose. I agree with everything you said. In fact, I have proof, even with my aging mother, that the geriatric specialist, he actually asked me at one appointment, "Are you getting anything out of these appointments?" Because I didn't want medication for her. So he actually asked me, "Are you getting what you need out of these appointments?" Because I wasn't demanding a prescription being written. So that was a huge eye-opener for me. But now I've lost my point. I wanted to say that I think that doctors, I remember my point, and that's the way they're educated. They're not, in order to move to a value-based competition within our healthcare system, we've got to start today with how our physicians are educated. We've got to teach them this stuff, because it's not going to organically happen over time.
Yeah, in the U.S., they feel like they've done their job if they give you a prescription and a referral to another doctor.
Mm-hmm. Yeah.
And, I mean, the one that really jumps out at me is competition should center on medical conditions over the full cycle of care, because the system is so disjointed and disconnected and the opposite of holistic. And the body doesn't work that way. And I don't understand how we've gotten away with a healthcare system that hasn't worked that way. But going back to I just wanted to go back to the earlier point of the fact that this is going to have a lot of guidance and buy-in and mandating from the government. And that's where I really feel like the outsider, because at least in Canada, healthcare is seen more as a right, and there's there's the concept of universal coverage. And here in the United States, not only is it heresy to consider healthcare as a right, but I feel that we've got a system and a government drive that we should be killing some of our population, either by withholding health care or not figuring out how to make it of value to the patient, because the goal of the system is that certain entities make the money that they've always made without any accountability. So, I mean, just a basic principle like healthcare is a right is huge, and we haven't even gotten there in the U.S. So it's pretty.
I feel you, Barry. I think John Sodden might be having issues with his microphone, or at least our ability to hear him. And he had put a chat into the mix a while back, and I'm not sure if everyone can read it or not, but I thought I would read it out. Just also, Barry, if you have any thoughts on this one particularly. But John wrote that he sees these principles and the entire rationale for value-based healthcare as laying the foundation for the Affordable Care Act. Any thoughts on that comment?
Can you repeat it again? Sorry.
Oh, I will, and he actually just typed some more. So I'm going to read 2 comments from John. One came earlier. Yeah, so John, the first thing John said is that he sees the principles and the entire rationale for value-based healthcare as laying the foundation for the Affordable Care Act. So that's a thought out there. I'm not an expert on the Affordable Care Act, so I don't know, Barry, if you have thoughts on that. And then he just also added to the chat, John said, the issue of education that is patient-centered, including coordinating a team approach of healthcare practitioners, happens to a very small degree at the University of Toronto. I took part in both facilitating and serving as a patient story in this course. Yeah, I mean, I know that, for example, for family medicine, there's been a shift towards teaching new grads about team-based care. This concept of value-based healthcare, I don't know that it's been incorporated. But those were John's two comments.
Yeah, I agree with his first comment. I mean, but if you look at how the electorate reacted to the affordable health care, they resisted it tooth and nail just because it was a change, and just because we've got an entire party that's pretty much driven to take away entitlements and not make sure that people don't believe that they have rights. And you've got people, up in arms against their own best interests. And then, I mean, luckily, after things kick in, people realize that this was better than what we had, at which point you've got another group trying to undo everything that was done and make it worse. So yeah, I feel like that was kind of an underpinning of the Affordable Care Act, and it had a long way to go because there was so much resistance that made absolutely no sense. I mean, it made sense, under the principle of I don't want to be accountable for what I do. I just want to, I want to make as much money as possible or get as many resources as possible without being accountable for what it's actually giving back in return.
So I agree. Barry, I agree with you 100%. I'm actually a dual citizen and really fortunate that I'm living in Canada and getting the health care that I am, and I have a sister who's in the States and is currently going through breast cancer treatment. And it's just mind-boggling to me that any small deviation that her doctor needs to do from any particular protocol, she has to reapply 7 different ways in order to find the ways and means to cover it with the benefits she's paid for. So I mean, it's mind-boggling, but I think it speaks to us, and it brings up an important point that in the U.S. it's basically a for-profit based healthcare system, and so the problem is like I was trying to say before, the pressure from the pharmaceutical industry and the medical devices industry is those were mostly all of those people that were behind, undo this Affordable Care Act stuff because this is going to put too much pressure on our ability to make profit and to do business. And that, to me, I felt that was the underlying problem. And I think this is something we have to be, really mindful of. That pressure is still going to be there going forward. And that's why I was saying in my particular disease group, there was constant pressure from the pharmaceutical industry to move away from what they actually did. And if I look at the full cycle of care, and this was interesting because it was kind of organically discovered by the physicians. I mean, it was after a certain number of years with the treatment that they started to realize certain patients developed serious cardiovascular problems. So now those physicians came together and globally said, no, now everybody has to have cardio-oncology follow-up, checkup throughout the care cycle that they're on any drug that for this disease group. And so they actually started to integrate and put together full teams. Like some people developed symptoms of arthritis. Some people had the cardiovascular issues. So they started to put together themselves these care teams that they work with in order to support chronic myelogenous leukemia patients throughout their full cycle of care. So that's fine, but now speaking to Louise's point, the patient. So what that has done for us, just so you know, that whenever we're talking to a patient, regardless of where they live in the world, if they're a fellow CML patient, and they report not getting access to a specific type of care, we jump on them and we drive them back to the key centers in their area and get them to support them to demand that they get that full cycle of care for their, it's all interrelated within their disease. It's not I have arthritis and CML. I have arthritis symptoms because of my CML treatment. It becomes part of that entire disease, and they can't just shift you around departments. So you get to the point where your CML hematologist oncologist specialist is actually sitting down with a rheumatologist or endocrinology if they have to, or cardiology. They're seeing you in a team, and sometimes you're all together in the same room, and I know that because I've experienced it myself. And I have to tell you, getting something like that put into place, the pressure from pharmaceutical and medical device industry was enormous. They really didn't want to see that breaking down of the silo and that team coming together.
So I think we only have 15 minutes left. I want to make a suggestion, and it can be completely ignored, and I promise I won't even weep about it, not openly, but I'm wondering if, and I'm going back to two specific comments. One, that there's an awful lot of redundancy in this chapter, and two, that the potential or defined principles on page 98 aren't really all principles. They're a mixture of a bunch of different things. Would it make sense for us as a group to, at some point, unpack these principles and what's said in this chapter and actually turn them into what they really are? By which I mean, if the first is on page 98, if the first supposed principle is actually a vision, which is that that everything we do is to the value of patients. Maybe we can take these principles and take what's said about each of them in the chapter and kind of turn them into what they really are, if that makes any sense, which is like probably a vision, some values, and then some sort of action.
Like tactics or objectives. Yeah, exactly.
They are, so tactics to get there. Maybe that would make this chapter more useful to us. Kind of rewriting of it from our perspective, just pulling out the important stuff. Is that just wasting everybody's time?
So, Louise, it's Cheryl, and kind of what I was trying to do with the notes that I sent out, because I took each of those. Yeah, and I'm sorry, I sent them out really late because I was away all weekend, but what I tried to do was take each of those principles as they broke it down in the rest of the book, and I tried to pick out some of the text to me that kind of, jumped out from the pages, that kind of supported what that was trying to say. And I tried to cut down on the redundancy, but I can't say that I actually did because it's really hard to do that. So that may help you, and that may help all of us if that's what we want to do, because hopefully it will show you that, oh yeah, so is that really a principle or is that really just a vision statement?
Exactly.
When did you send it out? Because I don't see it.
So you didn't get it, but you know what? I saw your email that you didn't get it, or your chat there. So I'm gonna send it to you specifically. It only went out like 4 minutes after the call started, Barry. So okay. I'll resend it to you now. Okay. And I only got down to, I still have more to go. So it may help. I don't know if we're going to be able to conclude it on this call, that's for sure, because it's so lengthy. But it may help us all do what Louise was suggesting, And between now and maybe a week or so from now, you know, people can write back and see what they think, you know, principle or not, on the 8 principles. Go through that list of 8 principles.
Yeah.
And
I think
tell
that
me
would,
what it,
yeah. I think it would be great if we could reconstruct the chapter in a way that makes more sense to us.
Yeah, I mean, the chapter, you know, tried to give examples of each of these. I mean, some of these are just so obvious and such a no, you know, such no-brainers, but then others seem counterintuitive. Like, for example, um, uh, uh, results. Let's see. No, let's see. High quality care should be less costly. So I really had to look at that and you know, kind of, and then you had mentioned this on a previous call, Louise, I think about, you know, them talking about making competition regional, national, or international versus local,
Yes.
and how that would work.
Mm-hmm.
And one of the things that was in there that I thought I would flag is the one around innovations that increase must be strongly rewarded. And in the book, it talks about innovations coming out of clinical trials versus what would be a part of this model, to see studies using risk-adjusted results data focused on detailed examination of what organizations, processes of care, different stakeholders in the system, how their results are sort of impacting outcomes, or how whatever it is they're doing are impacting income, and the resistance to that. Where's the money going to come from, and that kind of thing. I thought was really interesting.
Yeah, so I don't know if we reached a consensus about whether we'd like to kind of reconfigure this chapter under headings that we think more accurately represent what is being said, rather than calling everything principles that we don't necessarily think are principles. Maybe we can do that working off of what Cheryl Ann had sent us. Does that make sense? I think it would be easier for me, but maybe that's just the way I...
So what would be the mechanics? Will we just do it via email, or?
Yeah, what, I don't know, what would be the best mechanics for that?
I think we should send everything to Leah.
Yeah.
We can service to that and have Leah kind of pull together everything she gets from all of us. That's certainly okay.
I'd like to add something to it, and if you don't agree, that's okay. I won't be hurt or offended. But because I've mentioned, it's kind of the big piece that's missing in here is what is going to be the reaction of the pharmaceutical and medical device industry on this, because that whole piece is just not in this book from what I can see. It's really focused.
It's interesting you mention that, because the people who first brought me this whole concept weren't that people from the Canadian pharmaceutical industry. So I'm not saying...
I agree with you. That's what I find funny.
Well, I think
you know what I think. I think in their heart of hearts, they believe that they're how can I put this? That the wave of the future really is in innovative medicines rather than hospital care and a lot of these. I think I think they think at the end of the day they'll make more money.
Well, I mean, I felt like it was
right, and you know.
I felt. Oh, go ahead.
I'm saying I don't actually care whether they are wrong or right. I just want whatever creates the best outcomes for patients. So if it turns out that it is more money in drugs and less money in hospitals, okay. If it means more money in rehabilitation centers, okay. I don't actually, it's not I don't care, you know what I mean. I don't have a vested interest in the answer to this question. I just want the question answered.
I haven't read the whole book, but it looks like it. Do they spend about maybe 11 pages on this mildly sort of when they talk about implications for suppliers in chapter 7, which is not a lot, right? So since there's entire strategic application chapters for different stakeholders, I think as I had said, I haven't read this far down, but it looks like maybe they touch on medical devices and pharma, and then other whoever else would fall under suppliers for about 11 pages or so in chapter 7. But you know, certainly it's not in this chapter.
I agree with you 100%.
But this is more of an overview, right? Before they start unpacking. But 11 pages certainly seems very brief, having not read it, as you said, compared to sort of the power within the system and that's held by these stakeholders, as you really have illustrated through the CML example too, Cheryl.
I agree with you. I think, and John was saying that he says that he would like me to finish my notes, and then everybody could use my notes as a starting point to do what Louise was suggesting. So if we can move towards a consensus on that, I think it's a brilliant thing for us to do, because it would certainly help us know how we're going to act as patients in getting our voices heard and driving something like this to our healthcare system.
Yeah, it starts to create the key messages in a way that makes more sense, I think, for all of us. Does anyone not think that this is a worthwhile exercise to undertake? And don't forget to unmute yourself, because if you're speaking right now, we can't hear you. Okay, so if I understand correctly, what's being suggested is that Cheryl Ann would, and please do take a look at the slides that both Barry and Cheryl Ann have sent, and thank you to both of you for the work there. There's a lot of good questions and examples and stimulating thoughts in Barry's slides as well. But so if I understand correctly, what's being asked is that Cheryl Ann, for next steps, Cheryl Ann will complete the review she had done and send out a finalized document that everyone will take a look at. And basically people are going to work from that to try to reconstruct basically. Sort of, I don't think anyone disagrees with the key messages, sort of what's in this chapter, but really try to sort out, what these different ideas are. Does this represent more of a value statement, or are these goals or these tactics? So and try to bring these ideas, reconstruct these ideas in such a way that we feel they're being stated more accurately, as whether they be vision, values, / principles, or more objectives and tactics to achieve the vision and the principles. Does that make sense?
I
and then
agree.
you're going to send that all to me, and I'm going to bring it together and share it back out with the whole group before the next call.
I agree. And one more point, I think you should also send Barry's notes too, because she's actually the one who brought up the challenge of, is this really a principle or is it a vision? And I think, Barry, if I'm not mistaken, I looked at your note very briefly, and I think you actually have a definition of a principle in your note. So I think that would be very good for all of us to kind of keep that in mind while we're looking at my notes,
And the only other thing I would like to suggest is, could we, at least as a start, work on the same headings, like put down what you think are value statements, put down what you think is a vision, put down what you think are principles, however you define them. But at least if we could, put down what you think are actual tactics, put down what you think is a strategic direction, like so that we can all clump them together when we may all not agree at the first go round as to how to categorize them, but I'm sure that when we talk to each other, we'll come to a conclusion. And the great thing I think about doing this is that it will give us a much better, I think we can almost do it on a one-page kind of chart that will show us kind of the roadmap from the very high-level vision of the world we'd like to see all the way down like a waterfall. I think that it could really be helpful for us going forward, I think.
Yeah, the other good thing about it is it could be applied to any country. It could be applied to other systems other than health systems. It's like you said, a roadmap or framework that can be used in multiple places and entities.
Yeah, true. That's right.
Great.
Okay.
So to that idea of using some common sort of headings to group this, it sounds like basically sort of vision, values and principles, strategic directions and tactics. Does this sound like a reasonable way to try to commonly group these?
I think so.
Yeah, if you find that you have some outliers that don't fit within those sort of four, then by all means make note of that and send that in to me as well, and I'll make sure that that those kinds of questions are captured in what goes back out to the full group.
Perfect.
Yeah, good parking lot stuff.
Yeah. Okay, so Cheryl Ann, when you're done your final cut, could you share it with me? Then what I'll do, just so people don't get lost in a million emails, I'll send out Barry and Cheryl Ann's final documents in one email with just a reminder of what the exercise is, particularly for those who aren't on the call today. I'll give a timeline. Obviously, people can go past the timeline a bit, but just so that we're people often are a little more motivated when there's a deadline, even if it's to miss the deadline and then send it afterwards. So great.
Thank you so much.
Thank you so much to Cheryl Ann, to Barry, to Mark for all the hard work and for facilitating great conversations. Just a reminder that our next meeting is on August 23rd, and we will review what came out of the exercise we're going to do in between meetings on that call. Also, we have Chapter 5 and Chapter 6. Strategic implications for healthcare providers, being led by Kathy Kovacs-Burns and Gilbert Mubazi, and Chapter 6 is strategic implications for health plans with Rose Tong facilitating us. So thanks so much to everybody.
Thank you.
Thank you.
Bye.
Bye.
Have a great day.
Bye.